This week on the BackTable podcast.
And when I accepted the job and came here and didn't have any commitment to any of the resources that I was verbally promised, I resigned. And Eric Vaughn, the chief of urology at New York Hospital Cornell, said, you can do that once in your career, and the next time you try it, they're going to let you go out the door. But they responded very generously and graciously, and we got the Kimmel building built, and we got resources to start bringing people in to build the infrastructure for a sport rail, and we start being able to enlarge the faculty.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Dr. Peter Scardino, who's really been an absolute legend in our field of urology. Welcome to the show, Dr. Scardino. How are you doing today?
I'm doing fine. I'm delighted to get a chance to join you.
As I was preparing for this, Dr. Scardino, I was thinking about introducing you, and I didn't want to spend our entire time in that introduction. And I thought perhaps I would have you introduce yourself, maybe covering some of the personal and professional highlights that are most meaningful to you.
Well, I'd be glad to try that. I have a long history of urology in my family. My dad was a urologist and had a lot of influence on me growing up and even in my professional career while he was still active and healthy enough. And it's been a joy. Sometimes it was rough going, but it really was a joy to have a father who knew the field and we could have great discussions and arguments with. I was born in Portsmouth, Virginia, Portsmouth Naval Hospital at the very end of World War II, just after VE Day. And my dad was in the Navy, and he had come to the Navy from a residency at St. Louis Hospital and St. Louis University, where he met my mother. My dad was from Texas, and he got an internship in pediatrics at the hospital in St. Louis. And he met my mother there, and they dated for a year. World War II broke out. They got married shortly thereafter, and Dad spent his next 4 years in the Navy. And they were stationed in New York. Dad used to, when the ship came in, he would get off the ship and go spend the weekend with my mother, although he had no shore leave. He just walked off the boat and said, they'll know how to reach me. And he said, this is important for you to understand that it's better to ask forgiveness than permission. And Dad was full of sayings like that. We moved to Savannah, Georgia in 1949. There were 3 children, and Dad desperately needed to get a real job and earn some money. He was from a relatively poor family, and they already were struggling by taking care of these 3 kids. And they moved to Savannah, and Dad's career took off. He was very capable. He joined another Hopkins graduate from the South, and I grew up there and on the saltwater rivers around Savannah and Hilton Head and the coastal Georgia and South Carolina. Nothing I loved more to do when I was in grammar school than get a couple of my friends and go over to the river on the weekend. It was about a 30-minute drive. It was out in the middle of nowhere. We camp out on this piece of land my dad had. There was no building on it, and we'd camp out, make a fire, and catch and cook our own dinner. We'd catch shrimp and crab and fish. And I thought it was so wonderful that years later, my mother saved a letter I wrote to her when I was in some emotional distress. And the letter ended saying, but don't you understand? All I want to do is go to heaven when I die and live on the saltwater river. And so I was quite taken by that. I went to high school in Savannah, a private high school, and I wasn't a very good student in grammar school, and it wasn't very interesting or exciting. But I got turned on to academics by a tutor. His name was Mrs. Smith. She tutored me and a friend of mine, a close friend, when we were in the 8th grade. We had not taken any language or any algebra, and the private school required that before you could enter the 9th grade. So we took tutoring, and she just made it the most fun, interesting thing I did. And I turned into a straight A student and loved the academic world, and began to get interested in what my father was doing. And I would go out to the operating room. In those days, a surgeon could take anybody he wanted to in the operating room, he or she. And Dad, I asked him if I could go see an operation when I was about 13. It was a nephrectomy. And I was standing around feeling very nervous about what to do. And all of a sudden, my dad walks up to this man, takes his knife and makes this big slashing incision. And I just took one look at that and fainted on the floor. So the nurses caught me in time and I woke up on the floor. What happened? What happened? But that didn't last very long. And I really got interested in medicine. And in the summertime, and after my 10th, 11th, and 12th grade, I went to a special summer science program sponsored by the National Science Foundation at St. Mark's School in Massachusetts. And it was a rigorous 8-week crash course in science. And there were 22 students and 4 second-year students. 4 of the 22 were asked back the next year to sort of be junior faculty. And I came back the second year, and by that time I was hooked on medicine and biology and science. And I really wanted to go to a school that could give me a deep education in that area. And my parents had a good friend who lived in New York but was from Savannah named Danny Zarum, and he was about halfway between my age and my parents' age. And so we could be friends both in our own ways. But I thought Danny was really the most wonderful man I knew. And he had gone to Yale, and he had put his 2 brothers through Yale. So I was thrilled to get into Yale and had a great time. After freshman year, I decided that staying in the science lab when there was so much of an opportunity to study the humanities in such a rich culture, I couldn't bear the idea that I would be in the science lab 5 days a week. So I switched my major to religious studies. And I was interested in religious ideas and how much they tell us about human beings and what the nature of being human is. And I had a brief thought that I wanted to stay in religion and study the Bible and the historical Bible and write things about how relevant it was to current times. And then I thought about it, and by then I was married to my high school sweetheart. And the reality of raising a family or being an academic in an obscure area, quickly I got over that, and I went to Harvard summer school and took organic chemistry. And thank God did well in that, and then came back and took physics at Yale. And I applied to 13 medical schools. I really wanted to go to Columbia, but I got into Duke. I wasn't that thrilled about going back to the South, but Duke had a good reputation. It was a good school. I got there, and I was just overwhelmed. They had put in a new curriculum the year before I got there. We were the second class in it, where all the basic science work was done in the first 9 months. And then beginning the end of the first 9 months, you could take a basic clinical program, one of the requirements, or you could take an elective. And I did OBGYN that summer. And then sophomore year, you do all your required clinical courses. And I did those. And then the last 2 years of medical school, I spent in the lab working on the renin-angiotensin axis and the very good nephrologist there. And that was when angiotensin was just being appreciated, and we were trying to develop a radioimmunoassay for angiotensin. But Duke was wonderful. Duke treated medical students like colleagues. The faculty were gracious and generous and fun to be around and rigorous in their academic thought. And in my senior year, they had the dean's hour where the dean would select a particularly accomplished scientist, a physician or scientist, to present a lecture to the whole medical school. And they had Carlton Gaduchek, who discovered slow viruses, which have subsequently been identified as prions. And they didn't know what they were, how they were transmitted, but he had the first evidence that the transmission was almost certainly from the brains of the deceased leader. And they would burn the body of the deceased leader or cook it and pass it around, and the leaders got to eat the best part, which was the brain. And that's how they probably passed kwashiorkor and those diseases on to the next generation. So, and we went out to dinner with him, and we had a great fun time arguing and discussing the Vietnam War. And I graduated from Duke and wanted to go to the Mass General Hospital for my residency. There were several Mass General faculty at Duke. One was Jim Weingarten, who became the director of the NIH. And I took a wonderful course in the molecular basis of disease. And it was a great seminar and really made me attracted to trying the Mass General. I went up there and did an elective for 2 months, and I just absolutely loved it. When I was at Duke, I took a senior year elective on urology, and I was in the operating room for a resident to do a radical perineal prostatectomy. And we all got scrubbed and dressed and draped the patient, and the nurses were ready. And they turned to the chief resident and said, well, aren't you going to start the operation? He said, I'm not starting this operation until the attending is here in the room. Last time we did that, we got into all sorts of trouble, and I want the attending in the room from the beginning. So we waited for about 15 minutes, and the attending came, and the operation went fine. And then I got up to Boston, and Donald Skinner was the chief resident. We had a lot of fun together, and I got to know him. And one day I was assigned to go to the operating room and help him with a radical perineal prostatectomy. I got there, and the patient was up in position for perineal, prepped and draped and anesthetized. And Dr. Skinner was draped and prepped and was draped and all set to go and wasn't starting the operation. I said, well, Dr. Skinner, are you waiting for the attending? He said, hell no, I'm waiting for the junior resident to come here. I told him he was going to do one of these skin to skin before he finished the rotation. That gave me a feeling that there were really quite differences between hospitals in terms of what they let you do and how much responsibility you had. I was thrilled to work at the MGH for 2 years. I finally made the decision to go into urology. I kept procrastinating, but MGH had a chief, George Prout, who wasn't the most delightful man in the world. And the people at UCLA seemed to have a good time, but learn a lot and were highly productive academically. I made a decision to get out of my offer to be a resident at Mass General and go to UCLA. My wife at the time didn't appreciate it one bit. She said, why do you have to take me to California? Why can't we go somewhere more familiar like London? But she had a great time there too. And we really enjoyed the 3 years at UCLA.
Perfect. And, I was kind of chuckling to myself at some of the similarities. One, the first operation I ever saw, I also promptly passed out and had some concerns, but was able to quickly get beyond that. Secondly, I actually also studied religious studies as my major in undergraduate, and I felt like it was fairly impactful in my ultimate decision to pursue medicine. It kind of fulfilled some kind of deeper purpose, I suppose. So maybe going back to the beginning, I appreciate the hobbies, spending time on the river. How would you say that your high school classmates might describe you, Dr. Scardino?
They thought I studied too hard. One of them, a few years later, told me, I didn't think you were all that smart. I thought you just worked harder than anybody else. And I said, yeah, I was too dumb to know you could get by with less. I had good friends in Savannah and good friends in Georgia, people that I'm still in touch with from my days. Of course, a lot of them have grown older and quite a few of them have died, but I still have good friends from that area. And my kids love it. They love the rivers, the saltwater rivers between Hilton Head Island and Savannah are fun to boat in, water ski, shrimp, crab, and really live a life on the water. The trouble is there used to be nothing but a few houses over there on the river. Now there's a few houses on the river and many more shopping centers than houses on the river. So it's really changed. But once you're out on the river, you don't notice the shopping centers, and it's wonderful.
You mentioned, of course, that your father is a urologist and a prominent urologist. And in my research, there's actually some named procedures after your father. Was it always kind of medicine for you? Subsequently, it sounds like urology obviously became the choice, but were there other careers that you had considered?
When I was in high school, just learning about science, I was really interested in the atom, the understanding of the atom and the relationship between atoms and molecules and the discoveries that were coming out quite regularly. That I guess DNA was discovered in 1956 and when I was 11 years old. And it was written by the man who discovered it, Watson, Jim Watson, was really made science sound like a lot of fun and as well as rigorous work. I sort of came to urology slowly. My feeling was my dad was in it. He was well known. He was successful. I didn't want to be riding on his coattails and have everybody say, oh, you're Peter Scardino's son, aren't you? So I really leaned away from urology and my friends got so sick of talking to me about, did I want to do general surgery or urology? They said, just shut up and make a decision. But the first time I went to the AUA to give a paper was in 1994, my first year at an AUA. I wasn't even a urology resident. I was at the NIH doing a fellowship before residency, and I got up to the stage, and the president of the AUA, who was a good friend of my father, introduced the next paper as ileal conduit urinary diversion will be delivered by Dr. Peter Scardino. And I walked up to the microphone, and he said, wait a minute, you're not Dr. Scardino. And of course, once everybody heard that, my name spread all over urology, and there was no escaping everybody knowing I was my dad's son. But he kept his distance professionally. We would talk about things and much more than urology, but it was fun to have him, to see him go off on a few visiting professorships. And I remember he filled out a questionnaire about your life choices. And one of the questions was, if you had to do it over again, what other field would you go into? And he said, none. There's no field I feel like I would have been happier in than urology. And I felt the same thing all the way through.
Well, the only reason I ask is, it's interesting, the interest in science and rigorous work in medicine and urology are the areas that you've highlighted so far. Externally, of course, there's that component, but there's also the leadership, the statesman, the administrator. Actually, a common friend of ours, Scott Egner, mentioned that you would have been a great Fortune 500 CEO or a senator. And I was just curious if you ever felt like roles along those lines were appealing to you from an earlier phase, or was that a later development?
Well, that's interesting. I remember a conversation I had with Scott about that. What interested me about management and administration and business is that it seemed to me that doctors in general didn't know how to manage their staff, or how to create a business model, or how to conduct a business nearly like they should, particularly if you were chairman of an academic department. You were responsible for not only the income, but also the expenses, and you had to make the budget balance and pay all the staff. And it was really challenging, and there was no training in it. So a few of the young faculty who started at Baylor the same year I did got talking about this, and we approached the president, and he introduced us to a retired businessman who was his advisor, who sat in the office right next to him, and he sort of bounced everything by it and got a different point of view and an important perspective. So he kind of adopted about a group of 6 or 8 of us, and we decided to go through a course like hospital accounting. What does a hospital really mean by net profit or gross profit? Or when they say, okay, we'll take 10% of what you bring in, how do you know whether that's net, gross, or how does that calculated? So those things seem to me very important in personnel management, personality types. So he set up a series of informal lectures for our group where he would bring in the CFO or the chief accountant or department chairman and give us a talk about what he does and answer our questions. That stimulated me to go one step further, and I took a month off, and when I was a junior faculty member, and studied business administration at the University of Houston. They had these refresher courses for businessmen from around the world, and it really opened my eyes. For the first time, I could open a book that had a clear answer to the question, what's the best compensation system we should have? And I hired the Boston Consulting Group to give me some horsepower to change the faculty practice plan, because Baylor was stuck in a situation where the faculty members got 50% of anything they earned, and the department paid all the bills, and the department was gradually going broke, but the doctors were doing very well. And I had to sit down and tell them, guys, we pay our expenses first, and then we divide the rest according to whatever rules we want to have. And if it hadn't been for that experience and that backup by the people at the University of Houston, I don't think I would have ever tried anything like that. I was a young faculty member coming into a mature department with some pretty famous people, Don Griffith, Eugene Carlton, Ed Gonzalez. It wasn't easy to get them to go along with things that were important, but that helped me a lot once I got to be chief of surgery at Memorial. I had not a formal education in how to be a department chairman, but a lot of experience and some good bit of academic information to make it feasible to carry on a complex administrative job like that.
Yeah, I appreciate you sharing that. And it sounds like you had some fairly dedicated mentors throughout that process that were interested in helping you fulfill your interest and knowledge base in hospital administration, the execution of responsible business. Is that the case?
I can't tell you, DJ, how important I think mentors are in a field like urology. It's small enough that everybody gets to know each other, but it opens so many doors so quickly, and it introduces you to so many people and multiplies your opportunities by so much to have a really good mentor, a whole series of mentors. So I was very lucky in each stage of my career that I had a very effective and knowledgeable mentor who had my best interest at heart. Sometimes it led to conflicts. When I was at Duke and the chief of urology, Jim Glenn, offered me a place in the residency program when I was a sophomore in medical school. And as I kept looking around, I thought, there's lots of other places that have programs that seem to me that would be more fitting and more helpful to me. And I got interested in the MGH, as I told you. And when I told him I was going to go to the MGH and not come back to Duke after I was at NIH, he got furious and would not speak to me for a while, which I thought that was sad. It suggested to me that he was interested in me, not so much as what was best for me, but what was best for him and his department. But a mentor, I've been very lucky at Houston, Gene Carlton at MGH, Don Skinner at UCLA, Joe Kaufman and Will Goodwin have all been critical people in my growth and development in the field. At the NCI surgery branch, Steve Rosenberg was there. So I think it's one of the most important things we can teach our residents and fellows is how important it is to attach yourself to a good mentor at each step of your career and really get some guidance by somebody who gets to know you for a number of years and can help give you good advice.
Yeah, I think that's an evolution. Just this past year, there was a medical student that I mentored who ultimately matched at USC. He was absolutely tremendous. Nothing would have made me happier than to have him stay in San Diego, but that was what was best for him. And he asked me to actually come to his graduation ceremony and hood him. And I would say that, it was kind of one of the professional highlights of my career that you are able to engage with a student or a resident or a fellow and sincerely look out for their best interest and help them get where they're going. Well, it sounds like kind of on the administrative leadership end of the spectrum, you kind of engaged early on, which clearly suited you very well for a career in leadership and administration. Maybe let's talk a bit about your mentality going into it from a urology perspective. Let's not forget that your contributions towards prostate cancer are unparalleled. When you got there day one at Baylor, were there certain things that you're like, these are absolutely critical, mandatory elements of my practice to set up the career that I would like?
Well, I had that all in mind. I thought I was going to hit the road running, and I had such good training and great advisors, and I knew the field, and my dad was in it, and I was just going to go a mile a minute, but I got my expectations were way too high. And, the fact is, it takes a while to build a practice. You just have to get to know a certain number of people, and your name has to get around, and people have to learn to trust you and see how you do in the OR and see how your patient care is before you can really expect to have a large number of patients. And I remember I went out on a fishing trip in Galveston Bay with one of the private practicing urologists who was a very good guy and very much involved in resident education. And we were fishing out there. And I said, the truth is I'm getting kind of discouraged about coming here. I said, you were born here. You've known these people all your life. You did your training here and you started your practice in a multi-specialty group that your brother was in charge of. How many years did it take before your practice was as busy as you wanted it to be? He said, it took 7 years. And I said, you mean after 2 years, I don't have to give it up and say I'm a failure? So, the same thing is true with those academic skills, the management skills. You can spend some time learning those things, but you may not have, for one reason or another, a chance to really use them in practice. they came in handy for me, and it worked out for me. But I would say a healthy interest in management and administration and maybe some elective time. But I've rarely advised anybody to go to business school or get a master's degree. I think you could, but the question is, are you going to spending that much time in management? Are you going to move your primary interest away from the surgery and the medical care and the research that you came in the field to do? An administrator, at the end of the day, can change leadership, and next thing you know, you had a big administrative role today, and tomorrow you don't. Goodbye, thanks. That can't happen to you if you're practicing medicine, unless you're having catastrophic bad result. But if you're practicing medicine and you want to work harder or not as hard or change your partners, that's completely up to you. The laws in most states don't allow the hospitals to eliminate somebody from their staff except for egregious cause. And so it's very hard to force somebody out of a hospital.
We've talked about the administrative leadership, education, kind of revamping of the finances. But of course, maybe from the outside in again, my perspective, looking at your career at Baylor, is the meteoric rise from assistant professor to department chair was really the work you were doing in prostate cancer. Is that true?
Well, I think the thing about my work in prostate cancer and about coming to New York are two overlapping but a bit different stories. I was doing very well in Houston. We had first spore in prostate cancer. We were operating on 800 men with prostate cancer a year. We had 8,000 square feet of lab space, a full-time molecular biologist, about 4 people on the staff who were devoted full-time to prostate cancer. But when I was offered the job at Memorial, I came up and looked at it, and I didn't see any of those resources. The urology seemed to be tucked away in a corner without much to call on to try to build the practice and expand it and improve the quantity and quality of patient care that we did. And that's where my business experience helped with that transition. It helped me to understand how the financial system works, who is it really written for, and how can you have some control over how much money you can get to carry out your program. And so I learned a lot about philanthropy when I was at Baylor, and I brought that knowledge here. That was tremendously yielding to our infrastructure. A lot of the money that I received from donors, we used across the urology department to support all sorts of infrastructure, including Kettering Vickers as statisticians and the medical editors group, and a whole range of resources came to us because of that. I think the main reason Memorial invited me up here to look at this job was that there wasn't anybody on the faculty who was doing radical prostatectomy and getting the results that Walsh and Catalona and others like that were getting. And so they were losing patients who were particularly patients who were donors to the hospital when their family members were sick, and they were going somewhere else for their treatment of their prostate cancer. And that was really painful for the department, for the institution. So they really wanted to get somebody who was a known surgeon who could establish a standard of care that was comparable to these other national programs, and understood that came with the requirement to do research, because research is the only way we learn how to do better patient care over time. And that's what they were really mostly interested in. And when I accepted the job and came here and didn't have any commitment to any of the resources that I was verbally promised, I resigned. And Eric Vaughn, the chief of urology at New York Hospital Cornell, said, you can do that once in your career, and the next time you try it, they're going to let you go out the door. But they responded very generously and graciously, and we got the Kimmel building built, and we got resources to start bringing people in to build the infrastructure for a spore grant, and we started being able to enlarge the faculty. And that was the hospital's main practical goal, was to keep the prostate cancer program from dying out and getting so far behind. But my interest was to build a great neurology department and a rebuild program that Witt had done so much to make world class.
That's fascinating. And some elements of that at a much smaller scale resonate with me. So you've got a tremendously successful clinical practice. You've built a research infrastructure that's second to none with the SPOR at Houston. And then one fine day you say, okay, it makes sense for me to leave all that behind. You could even maybe say that legacy behind as you're now approaching your mid-career, and to do it all over again in an unfamiliar area with limited resources, perhaps some friction to obtain those resources. Reflecting back, was that a period of trials and tribulations that was worth it? Did you grow individually? Were there sacrifices? I mean, business administration, busy clinical research, infrastructure development, and then of course the personal aspects, family life. Maybe you could comment a bit about how all those three plus a transition came together.
Yeah, I think those are important questions as I look back on my career. I think the main thing that attracted me to leave Baylor was not that anything was wrong with Baylor. It was that Memorial had so much to offer in the realm of collaborative, multidisciplinary science, clinical and laboratory science. I mean, the quality of the scientists here was so much stronger and so much deeper, but the clinical faculty were outstanding, internationally known in their areas. The expertise in associated disciplines that you need to work with, radiology, pathology, medical oncology, radiation oncology, were largely a whole new level of excellence and experience than I could get in Houston. Remember, Baylor is basically in MD Anderson's parking lot. So anybody interested in oncology drifts towards MD Anderson and away from Baylor. The only advantage of Baylor was that it was essentially private practice model. So if you hustled and really did everything you could to build your practice, you could make it grow quite a bit. But it took a lot of effort. Whereas when I moved to Memorial, I was booked up in the operating room within a month. I was using up all the operating room they would give me. And the patients were being drawn here, not just because of the chief, because of Dr. Fair, or because of me, because I was new and had a reputation. It was the institution that had a great reputation for cancer in general, and the expertise across the board. There were no areas of oncology that we were weak in terms of analyzing data, making clinical judgments. We were everywhere. It was the state of the art, but that was not true at Baylor. I felt like I had done as much as I could do with the surgical program, and that it had to become a multidisciplinary, protocol-driven program. If we were going to make any real progress, I needed to be part of a team. And I think that turned out to be very true. There was a lot of division of attitude towards making urology a department, towards giving urology its own building, towards supporting urology with space and resources, giving us access to philanthropy. All those things were positive for urology, but were sometimes criticized by other people here. And it bothered me. I mean, these were wonderful people who I was so thrilled to have been given an opportunity to come up and work with. And yet here we were acting like we were each other's enemies, or we were only going to succeed if somebody failed. And it took a long time before that began to heal. I think by 2006, when Dr. Brennan retired or stepped down as chief of surgery, Bob Wittes was the physician-in-chief. And Bob, I had known through the NIH and through previous grants. I was on the search committee, and we identified two excellent people to be chief of surgery. And Dr. Wittes just wouldn't accept them and called me over and said, "I want you to be the chief of surgery." And I said, "Well, how can I turn that down? I mean, that's never something I ever expected or wanted to do." I didn't realize I realized what an enormous administrative burden that would be. And it meant that I wasn't going to be able to have as big a practice, and I wasn't going to be able to do as much research as I could have if I had not taken it. But I thought it was a wonderful challenge, a great opportunity. You know, when I had all that trouble deciding was I going to go into general surgery urology, here was a chance to be a general surgeon more or less too. So that was a lot of fun. And I think we all finally got over the hard feelings about it, and things have moved on. But trying to do everything, which I'm a master of trying to do too much, you can pay a price for that in your personal life. And it effectively ended my marriage. I mean, I had been married for 37 years to my high school sweetheart, and I think she wanted to move up here to see if we could start all over again. And it just didn't work out. It was equal as much friction as there was at home. And it finally led to a complete break. Fortunately, things have patched up, and she and my children and I can go to things together. And I've remarried a wonderful woman who's been an enormous gift for me to have had the life experience with her. So I don't regret anything I've done, but I took the hard way, and it could be done easier. I could have written, 400 papers instead of 600, and probably taken off more time to be with my family and with my friends, and to have a life outside of medicine. So I'm trying very hard to make up for it now.
Well, I appreciate you sharing that personal part of your life, Dr. Scardino. And, I think we could run through the highlights at Memorial. And, certainly I was thrilled to be there at a retirement celebration at this past AUA in Chicago at Dr. Egner's house. Those might be more commonly known among the community, but I bet maybe some of the listenership would be more interested to know, is this kind of how you envisioned your life? Was this planned or strategized, or you worked hard and things fell into place? Maybe you can comment a little bit about that and some of the lessons learned along the route.
Well, I think the answer is I never had a plan to become a chief of surgery anywhere. I would have never been offered or have taken that position at Baylor or most medical schools. What was different about here is that although there are different surgical specialties that have their own, unique ways of doing things, the common interest here is cancer. So I would rather go to a lecture on brain cancer than go to a lecture on electroencephalography. And I'd rather learn more about colon cancer than I would learn about diverticulitis. So even though we were all 13 or 14 specialties in a department, which is very rare nowadays around the world, we had in common a disease that had many similar pathways of growth and etiologies across the fields. So what made more sense here was working in disease management teams, and people were really motivated to do that. That wasn't just a name for an attractive organizational idea. It really was the way we practiced medicine, that I could see a patient in clinic who had a complicated problem. I could walk downstairs from the third to the second floor and talk to Dr. Sherry. I said, "Can I send him down here and you see him, and then give me a call and we'll decide what to do?" And the multidisciplinary conferences, the opportunity to rotate on medical oncology, the fact that so much, got a lot of papers on my CV, but the vast majority of them are multi-author paper, of which I was a member of the group, and I might have been the 10th most active person in the project, but everybody contributed what they did best to the program. So I think that's a real strength of Memorial and something I saw. But I was thrilled to be asked to be chief of surgery and to know I had the institution backing. They really took a risk to appoint a urologist chief of surgery in a hospital with such strong surgeons as ours. But I thought I had been asked, and it was sort of my duty to respond positively. If that's what the institution wanted, that's what I would do, and I would give it my best. So it was more like an opportunity that came along at the right time in my career for me to do something, if I wanted to change focus from science and clinical research to a significant part administration.
And that certainly seems like the way it goes many times. It's a combination of the work ethic, the environment that you created certainly within surgery. And, perhaps some of those early days, some of the patchwork negotiations, et cetera, are what really brought your skills as somebody that could bring people together to the forefront. Well, perhaps as we, get an hour, Dr. Scardino, I would ask you to maybe do two things. If you were to maybe reflect and advise, say, your grandkids or the audience, what would that maybe look like? And then maybe talk a little bit about graciously winding down a career.
Sure, I'd be happy to say something about both of those. The other day I was talking to a fellow who I had some conversations with recently. And at the end of our conversation, he turned to me and said, "Do you have any advice for me as starting my clinical fellowship here?" And I thought about it for a minute. I said, I would say you have the most important thing in the professional success of a urologist, a urologic surgeon, a proceduralist, is the patient always comes first. If you don't make that clear to the families and to the patient and to the referring doctors and your colleagues, and that you'll drop everything to take care of a patient who's in trouble and needs help and needs your attention. And just because you've got a paper on at the AUA or you've got a ceremony to go to, I think your responsibility is to the patient first. It doesn't mean you always have to be standing by their bedside, but it means you have to provide them the level of care and make sure they get the level of care you hold yourself obliged to provide. And I think the second thing I would say is communicate. Don't sit around developing a great idea that you think is going to change the world without ever sitting down and talking to the people who might know a lot more than you do about it. Communicate in your research ideas, communicate clinically, make sure that if you're responsible as a fellow for patients who are in the hospital and something happens, make sure your attending knows about it. Take personal responsibility to give them a call, no matter whether it's 2:00 in the morning, and don't let him come in the next morning and find a patient with blood hanging who never got a call saying he was going to get transfused. So anything the family might notice, or anything that you're concerned about with a patient, communicate about it. You can never go wrong communicating, and you can always go right in doing that. And thirdly, collaborate. Modern science is essentially a team effort, that you can't do this molecular biology of cancer and similar things like that in a small lab with yourself and a technician. The model that I've seen fail time and again has been a surgeon gets a year or two of training in the lab, comes out and sees himself as a surgical scientist, demands, if he's going to be recruited to a hospital, demands lab space and 2 years of funding for his lab, and a lab technician and a nurse and a research nurse, and you get all that in a package and you think you've really got a lead on life. But if you don't deliver as much as you've asked for to justify all that work within 2 or 3 years, you're going to lose it, and you're going to be looked upon as somebody who's not realistic in his request. And you really want to collaborate and be an honest collaborator. Do what you can do, take care of what you know, ask and listen when it comes to somebody else. So those are the 3 things that popped in my mind about what I would offer advice to the future person going into residency or fellowship or a junior faculty position. Now, I'm not sure who else is in your audience and who I should direct comments to. The general recommendation I have is that you could do better than I did is live a well-balanced life. Take the time, make sure that your patients are fully covered and everything's fine, but take the time to take off and relax and get away and be with your family and friends and take care of yourself as you take care of other people. So we're at the end of my notes. I want to thank you and thank your whole team of BackTable for making this a smooth, easy to do experience and giving me a chance to reflect on my career, and hope that sharing those experiences in my perspective will be of some benefit to the people who listen to this.
Well, I thank you sincerely, Dr. Peter Scardino. It's absolutely an honor. And, the listenership may not know that it took us just a little bit to get the audio visual sorted out. And it's just classic. You never seem to be stressed or phased. I mean, whether it was a challenging operation, I'm sure you were juggling many, many hats once upon a time. Just from my end, you've really been an inspiration to so many of us. You've touched us from a training perspective. Your transformational leadership, is really inspiring to the urologic community, no question about it. The flexibility of thought, which we didn't get a chance to really touch upon extensively, early adoption of active surveillance, laparoscopy, focal therapy, supporting other people, taking true joy in other people's successes. These are all things that are extremely obvious to anybody that's spent some time with you. So I thank you for your time and for your wisdom and larger than life contributions to the field from the bottom of my heart. Thank you so much.
Thank you very much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by G. Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.